Good afternoon, everyone. My name is Al Gobey, for those of you who don't know me, and our chair, Anya, was at a meeting with Fletcher Allen, and she's on her way. And so we want to welcome Peter Cobb, and Peter will be presenting today. There's going to be a change to the agenda. The first item, the chair's report, will be moved to last on the agenda, so hopefully Anya will be here to make her report. Now I would ask for a motion to approve the minutes.
So moved.
Second.
All those in favor?
Aye.
Peter?
Okay, my name is Peter Cobb. I work for the Vermont Assembly of Home Health Agencies, which is the trade association of the VNAs. With me is Judy Peterson. She's the director of the CEO of the Center of Vermont Home Health and Hospice. And Nancy Warner is the director of the VNA of Orleans, Essex County. Between the two of them, there's probably close to probably more than 50 years of. Nancy's been on the job 43 years and Judy 29.
39.
Oh, 39.
No, 29.
29.
Dating myself. Oh my gosh.
Here's what we hope to do, and if we're going down a road that you'd rather we be somewhere else, please interrupt. But what I have is a presentation in front of you. Here's our goal. We'd like to give you a little bit about what home health is, a little bit of the history, and then how we think we fit in with health reform. So on your first slide, which is your second slide, introduction. My guess is most of you know what's on there anyway, but I'll go over it. Home care is pretty much just what the name is. Yeah. Hold on, let me move this sucker. Okay, the home care is home health services. It's
You want to pick one?
no, this is I
If
can
you
just
go up to
No,
slideshow.
I see.
slideshow, which is
Slideshow.
Slideshow is right there.
All right. Okay. Home health is basically health and related services in the home. Nursing, home health aid, physical therapy, speech therapy, occupational therapy, hospice, maternal child care, medical social services. My guess is most of you know that. There are 12 certified agencies in the state. 11 are VNAs, and 1 is a for-profit. There are about 22,000 people a year, and about 1 million home care visits. That's a lot of visits per day around the state. For many, home care offers it's a cost-effective alternative to the hospital and rehab facility. It's basically the goal of home care is just what we say it is to get people want to get well, stay well, and as long as they can remain independent. This chart I put on there mostly to show you that we don't just serve old people. If you look at the number of 65 and under and then 20 and under, that's 43% of our population that we serve. Of the 22,000 people or so, 43% of those people are under 65. So I think the assumption would be this is an organization that serves the elderly and the frail, but we're more than that. The next chart, the 60-40 split, that seems like it's a tremendous, but it's a less than it used to be. It used to be 15, 20 years ago, it used to be about 64 female. So the last few years, it's still predominantly female, but it is getting less so. But it's still 60-40. That's a 3-year average, by the way. That's 09, 010, and 011. That's a 3-year average. The next question, if I were you, is well, who pays for us? Well, we're paid for pretty much the same way everybody else is paid. Individuals and their families, private insurance, Medicare and Medicaid. We do lots of fundraising for home health. It's a huge part of our business. All of the home health agencies also get town. If you go to your town meeting in March, there'll probably be an item that says give a certain amount of the VNA. That's a significant part of our money. And grants in the United Way are also. All the VNA members, for those who have no insurance, there is a sliding fee scale. So you pay what you can afford. So all the VNAs have that. The next chart, I got back into who pays, and you'll see why this is. The next chart will explain why I have this one. Basically, that's a similar chart than we had. About 50% of the total revenues are from Medicare, and 28% are Medicaid. If you take operating revenues, it's a little over 50 and about 30. But for total revenues, you can see we're heavily dependent on public payers. It's close to 80% of our money comes from either Medicare or Medicaid. What's significant about that is I want you to compare that to the New England average. In the New England average, the Medicaid is 13% of the average. We're nearly 3 times that. Now, that's not a good thing. It's not a bad thing. It's just what is. I think it is, the reason that's the case is the Vermont legislature, and Mark Larson will definitely defend this, over the last 20 years, the Vermont legislature has made a move toward full coverage of everyone. Part of that has been the increase in people who get Medicaid. So the fact that we're 30%, and also part of that is the increase, I don't know how much you know about the Choices for Care program. 20 years ago, there was no Choices for Care. It started in 95 with under a different name, and then a new version in 2000. But that is now close to half our income. So that's why Medicaid is close to 30% in Vermont. And I also did it so you can see it over the years. In 1985, Medicaid comprised 18.2% of the revenues, and now, as you see, it's up to 28.9. So Medicaid has gone from a fairly small payer to a significant payer, basically a third of our business. And now you look at the Medicare on that. Medicare peaked in about 95, 96, and then has gone from a high of 61, 62% down to 50, and that deals with just things at Medicare level. They've changed how they pay. They've changed the kind of how they review and that kind of stuff. So those are changes independent of Vermont. Those are changes at the federal level. But at this point, it's for many of the agencies, it's around 50%, but that's an average. Some are more, obviously, some are considerably less. Of the 12 agencies, I already said, there's 11 for-profits. There's also numerous non-certified agencies in the state, and I would guess that BISCA has no clue, nor does anyone, how many people they serve or what they do. I have no idea. But there are like Homestead, Arminstead, LTC, there's quite a few. I have no idea how much their revenue is, and I don't think the state keeps that.
They don't get public funding.
No, they do not get public
So
funding.
they do it strictly on
They do it on
private money. Okay.
yeah. Another thing that is not on this chart that is you should know is the estimates of the care that is provided by family and friends is very high. I've heard it as high as 75% for those who are chronically ill. Each of us in this room probably at some time have taken care of a parent or we're about to take care of a parent. So those numbers aren't, when you're looking at the entire system, the non-certified and what we do as for our parents are not included. I've already talked about the 22,000 people. Home care is about 2% of the health spending in Vermont. It goes up a little, down a little, but it rounds that 2 to 3% in that range. The Vermont VAHA members subsidize about $5 million a year, state programs in that range, $5 to $6 million a year. And when you go back to where our income comes from, town funds, donations, in the past few years, most agencies have been able to take profits from Medicare to subsidize Medicaid. And this is an interesting statistic. The next one is, on any given day, there's actually we're making more visits into more homes than there are inpatients in the hospitals. There are more people getting some nurse coming into their home. Now, that doesn't include outpatient, but that is inpatient. We'll do several thousand people a day. I don't think there's several thousand people inpatient in the hospitals. If you take our 22,000, divide that into the population, 1 out of every 28 people receives home care. That's by far one of the highest penetrations in the country. And then lastly, sometimes we're not recognized for the fact that we're pretty significant employers. I think the visiting nurse in Burlington, for example, is probably among the top 15 businesses, maybe even the top 10, I'm not sure. But we have 2,500 employees statewide. And the total is around $100 million. As I said earlier, and this is how we differ from everyone else, 80% of our funding is publicly funded. The chances for cost shift are very, very slim. We have been able to use Medicare profits over the last few years, but that's drying up. So it's very difficult for the agencies to make ends meet when a third of your money comes from a money-losing source. Now, I don't want to exaggerate on the nursing homes, the 70% average. I got that from the Biscuit report, but I'm quite sure that most agencies are much higher than that, but that a couple of large nursing homes who have no Medicaid bring the average down to 70. But I think the average nursing home is closer to us, I think. But I got that from your report online. And 30%, as I said, the New England average is, as you know, as I said, is much lower than that. And the national average is even lower than that.
Peter, what are the dynamics of that? Why?
Well, the dynamics of it is when you're trying to run a business, a third of your payers, basically, are paying you less than cost. So if you ran a business and one out of every 3 people who paid your bills paid you considerably less than cost, it makes your business, it makes what you do different, how you react to the marketplace differently than you would otherwise. In other states, if we were the national average at 10%, certainly the agency's losses would be considerably less than they are now.
Peter, I think it's important if people are going to watch at home or people in the audience to know that Dr. Ramsey just arrived, and Dr. Ramsey and I were fortunate enough to serve on the Chittenden County VNA board for a long time, and we were peculiarly aware of the stresses of.
And I'm still serving as the medical director of the hospice program of the Champlain Valley, so still intimately involved.
The next graph is just a graph what I've already said. We're 83% public funding, not a lot of space to touch. Now this next chart on slide 12, I got all this information from CMS, and just kind of an idea. Here's what I think it says. I think it clearly says that Vermont tends to be less costly than other places. In 2010, according to CMS, we're about $4,300 a person. The national average was just about $4,560, and the New England average is about $4,900. So we tend to be lower. I think we were 14th or 15th in the rankings. The next few bullets, here's the way I see them. They may disagree, but here's what I see. See the average visits per episode, and then you get to the highest average episodes per beneficiary. I think the reason we have more episodes, do you all know what an episode is first off? Everybody knows what that is?
No, say it.
Okay, well here, basically the home health agencies are paid on 60 days of care. So each 60 days will be an episode, and then you start over again after 60 days. In Vermont, as you can see, we do an average per beneficiary of 1.79 episodes per year, which is much higher than the national average. I think that's to our commitment to chronic care. We have made a commitment in this state to provide chronic care services to people, and that's reflected in the numbers. We do fewer visits per person, but we have them over a longer period of time. And then just the next thing, it looks a little more dramatic on that graph. The next one won't be so dramatic. But if you look at the total revenue, this isn't operating, this is total revenues. From 108 to 114 over 3 years is only about 5% total. So that's a pretty reasonable. If one of your jobs is to keep in check costs, we're not the problem. And this chart even shows it even better. This is operating revenue. The last one was total. This is operating. As you can see, from 2009 to 2011, and I got these figures from the Department of Aging and Independent Living, we went from 102 to 108 in operating. Very small increase. Look at the bottom line in Medicaid. We were actually lower in 11 than we were in 09. So whatever stresses have been at the state level haven't been caused by the home health agencies.
Can you just explain a little deeper what you mean by total revenue versus?
Well, total
operating
revenue would include town funds.
So all donations as revenue?
Yeah.
Okay.
Operating revenue is what you get for what you give.
Okay.
What Medicare, Medicaid, private insurance, private pay, that kind of thing. So for services, operating revenue would be what the payments you actually get when you give service. Total revenue would be when you get in all your other stuff. So the gap would be 108 to 114. That difference would be town funds, contributions, investment income, that kind of thing. But my point with this, however, was if you look at the Medicaid line, it's basically level for the last 3 years. In fact, it's fairly level going back to 2000. So it's basically been almost a decade of very small growth on the Medicaid dollar. This next chart, I've done a couple of charts on visits because I wanted to give you both a long-term and a shorter-term look at home health. Go back to 1986. The agency's made 323,000 visits. Go to the end of the chart. In 2011, we made 931,000 visits. That's a pretty good incline over a 25-year period. Home health was clearly a growth industry in the 80s and up to about 90, into the 90s. However, since 96, it has leveled off or even decreased a little bit. And that has less to do with the state, more to do with Medicare. The kind of restrictions Medicare has put on home health and the kind of payments and all that kind of stuff. But over the long haul, it's a tremendous growth industry. Over the last decade, not so much. It's been fairly level. In fact, we peaked in 90, maybe 97, I think might have been higher, but the peak in visits was about a decade ago. And there is the short term. If you look at 06 to 11, you can see that the growth in visits has been quite small. So it's been not a lot of growth the past decade. Huge growth over the 30 years, very little growth over the last 10. Now, I just threw in this just so you know what Medicare certification means. Basically, any agency to qualify to give services must pass the Medicare conditions of participation. If you have questions on that, I'm going to ask these guys to answer them because I don't run an agency and I don't do this stuff on a daily basis. But basically, it's a fairly strict rules that you must follow to make sure that you do qualify for Medicare services, and that's why there are 12 in the state that do that.
How burdensome is the certification for you? It's not just the initial certification. We have to, we are surveyed to make certain that we're maintaining that certification by the feds, and it is burdensome. When they come in, they go out on visits, they interview people, they go through all of our records, they go through all our personnel files, they go through all our financial records. And the Bible, I was going to bring it, but the Bible of rules is about that thick. So, it's very definitive in terms of what a person has to have for conditions before we can bill. The billing restrictions are very detailed, and there's just not only are the regulations burdensome, but then the monitoring of such, because you can have somebody that doesn't understand, for example, and a bill will be given to the department to submit, and they might not have physician orders in the agency, and that would be considered fraud. So it is burdensome.
There is one of the one of the things that's been a problem for home care agencies is the amount of documentation our staff have to do to make sure that we're meeting all of the protocols and following all the regulations. So nowadays, for a home care nurse, at least half of her time, if not more, is in paperwork and documentation. And it's not what a nurse comes to do nursing for. You don't come to home care or a hospital or anywhere to be a nurse and have to do all the paperwork. So that's really been an issue for us.
The document for admission is about 29 pages and has to be done. And we have a fully integrated computerized system to try to cut down, because we were running about a half, and we have been able to affect that. But yes, it's very burdensome.
And is that mostly the federal Medicare requirements, or what about the state requirements?
They're also burdensome. Because when we were being certified, most of us were being accredited either by CHAP or by JACO. And when the designation program came into being after the antitrust suit that hit the state of Vermont, now there's a manual for choices for care. There's separate regulations, by the way, for hospice, and we're all certified hospice providers. That's a whole separate certification process from home care. when the designation rules came in, one of the things that happened was they tried to set up a new manual that brought pieces in from the different programs. And that's something that we're presently working on, is because all of a sudden the long-term care was seen as being, it was necessary to follow the same regulations as we were following for the acute care program. And that has been very dramatic for us. And for a small agency such as mine, that has been extremely burdensome.
Okay, I'll go on to the next one. Basically, obviously, we have state rules. I'm not going to read them there, but basically, we're in Title 33, Chapter 66, whatever, 63. And Act 57, which Nancy just mentioned, that was in 2005 or 6, I can't even remember anymore. Basically, what that did, lots of different things, but the main thing it did was, except for the for-profit, all the other agencies are limited by statute of what towns they can do. Addison can only do Addison County unless they have an agreement otherwise with the state. Chittenden does Chittenden and Grand Isle. Franklin does Franklin. And if you go onto the statute, it'll give the agency name and the exact towns that they cover. Now, the reason that we did this, for better or worse, I guess, is there was a investigation by the Department of Justice in 2005. And this gave state actions, I'm not a lawyer, so someone can throw me out of the room, but it basically state actions immunity and allowed the agencies to have a map. They didn't like them, we had a map anyway, they didn't like our map, because they said it inherently was non-competitive. So we were able to put that non-competitive idea into statute. And with that became the Act 57.
If I can interrupt just for a minute, Peter, the other thing that happened with Act 57 that was very dramatic and different for the agencies was the fact the state then mandated we had to do certain programs. And before, the programs that we were certified for were acute care programs, and our boards of directors decided if we were going to go out and do additional programs. So when Act 57 was enacted, then in fact the state made a determination, and that was when it was mandated to do choices to care and some of the other state programs.
And also, we are on certificate of need. Home health is one of the covered. Nationwide, that is not generally the case. When I started this job nearly 30 years ago, most states had CON for home health. I think it's down to maybe 15 or 20 now. It's not a lot. And the last state issue for us is the Medicaid tax. I'm sure you've dealt a lot with that with the hospitals and probably nursing homes. The tax is a significant burden for the agencies. For most agencies, it's either second or third highest cost center behind salaries. It's usually salaries, benefits, sometimes travel and the tax, or sometimes tax and the travel. So it's way up there on your cost center. This year, I think the bills are going to be $5.5 million, in that range. I'm not sure, but it'll exceed $5 million. As you know, the state then gets the federal match. So if we pay $5 million, the state gets $7.5 million. Now they got $12 million to play with. So we are one of the 3 industries that is taxed. The significance for you guys, and I know you know this, but is right now the tax is the federal the federal maximum is 6% of revenues. There's some pressure in Washington to bring that down to either 3.5 or 3. If that happens, Vermont, forget what you're going to lose for home care. Just from the hospitals alone, you're going to lose probably $100 million. But I don't know if that's going to happen because there's something like 40-something states who get this tax. So, but if it does go down, that's a huge problem in the future.
And actually, just to note, the DEVA issued a report on the provider tax,
Right.
Looking comprehensively at what other states have done and the different levels that we can distribute to all board members.
Yeah, and that would be good looking at, because if you're thinking of the long term and the federal government does drop that cap, that's a huge hole for the state. The next, I'm just getting into, these are state programs. I thought you ought to know, what does the state actually pay for now? When I say adult home care, I mean basically the traditional funding, the nursing, the home health aid, the physical therapy. Obviously, the state funds that, and it's funded through DEVA. The other program, the other large program, and has become, for some agencies, nearly half of their revenues, or maybe even a little more than half of their state revenues, is the Choices for Care program. Now, if you don't know you all know what that program is? Okay, the Choices for Care program is Vermont's key long-term care program. In Vermont, I think we're the only state that has this exemption. In Vermont, if you are sick enough and you financially eligible to be in a nursing home, you have a right to get services to stay out of the nursing home if you can manage. So it isn't just, in many states there's waivers, and usually they'll have like 1,000 or 2,000 people. Once they reach that, there's waiting lists. Vermont, as far as I know, and Patrick Flood, he's the one who designed it. As far as I know, Vermont is still the only state where it's actually an entitlement. It is entitled to stay home if you can. Now, obviously, everybody can't stay home for lots of different reasons. But if you can stay home with help, and you are eligible, both clinically and financially, then you can get on the Choices for Waiver program.
Peter, could I ask
Sure.
whether I'm right or wrong on this, but the early Elder Act 60, which provided more waivers to home care, and then the Choices for Care, we're bucking the trend on nursing home beds. Our numbers have steadily declined over the years. Is that a fair
I think that's correct.
characterization?
Yeah.
Okay.
Yeah, the Choices for Care waiver program is a success in many ways. Running the program, the problem is, just like all Medicaid programs, the revenues don't match
Right.
the costs.
So there's been a waiting list and
Well, there's not only,
funding?
there's not supposed to be a waiting list. The program is broken down into several levels. Highest need, meaning you really need to go to a nursing home. High need, moderate need. Just those three, right?
Yes.
Okay. In the highest need, if you are highest need, you can't be on a waiting list. If you're moderate need, you can be. And the moderate need waiting list has been controversial over the years, as anybody on the legislature knows. But highest need, there should not be a waiting. There used to be a waiting list prior to the current waiver. Under the old Act 60 that you're talking about, 1995?
Yep.
Yeah. There was like 1,100 people and then a waiting list. That waiting list for the highest need is gone.
Good.
So anybody entitled can get these services that are on the sheet here.
And how does eligibility work? It's by income, but what are
And
the...
it's both income and service need.
Acuity.
Yeah.
Yeah.
They look at things like functionally, what the person's able to do. They look at, there's an assessment form, a screening tool. Another thing is if there have been hospitalizations in the past year, the past 6 months. And it's all to determine whether or not this person is a nursing home level of care. And if they are, then they qualify for Choices for Care and could stay home in the community.
Is there an income max above which
It's
people are not
Medicaid.
eligible?
Medicaid,
Plus, right? Is it higher than the
a
normal?
little bit higher.
It's Medicaid plus. It's a little bit higher than the normal Medicaid.
Because it's long-term care Medicaid.
So as you look ahead with the, and don't let me jump you here,
Sure.
but if you look ahead with these dynamics, how much further progress can we make in that alternatives to nursing home beds using the existing?
Well,
structure?
the limit for home health isn't, the ability of home health to expand greatly is there. The problem is, for every patient we get, we lose more money. So I would think they can give you a different thing, but the problem for home health is the more people you serve, the more money you're going to lose. At some point, you got to draw a line and say, we can't lose any more money, or we just won't be here anymore.
Well, let me ask you then about now, for the first time, we've always had mission-driven agencies. Now we have a profit-driven agency. And what rules and regulations are in place to bring a home health agency into the state? They have to provide a broad array of services.
Right.
Okay. Are there any statutes that also require them to provide services to a broad array of payers?
Yes. The
Okay.
legislation that was passed in 205 does
That was at
include
50,
the
okay.
same restrictions that we have.
Yeah.
They have to provide the care to the people in need, and they have to do it without, they have to do the same stuff we do. So yeah,
Including choices.
yes. So that there were lots of reasons to pass the legislation. It wasn't just for the Department of Justice. It was also to make sure that we have a system that in the future does provide the services to everybody they need it. So the one for profit is under the same rules that we're on. What about the next program? The maternal child health is a big program for some agencies, especially Bennington. It's basically what it says there. It provides healthy babies, kids, and families, family, infant, toddler. That program has been evolving, and I haven't been able to keep up with the evolution. But there are services. All I can say is there's lots of services for children. Home health is a part of that, and that's an evolving system. This program here, high tech, the numbers are very, very small, but the costs are very, very high. You're talking probably on average $100,000 a person, maybe more. These are people who are ventilator dependent or they're dependent on technology for their lives. So I remember maybe 10 years ago or so, maybe 15, the state was trying to figure out how do we control costs. So they called it the 25 most expensive committee or something like that. They were going to look at the 25 most expensive people on Medicaid, and 18 of them, if my memory is correct, 18 of them are on this program. And then they realized, you know what? There's not a lot we can do to save a lot of money here if we want if we want children to actually be able to stay home, it's going to be expensive. So this program is very important, very small numbers, but very expensive.
So was this program based like on a Katie Beckett waiver concept?
Do you know what's based on that? I don't know if it's on the Katie Beckett
Where
waiver or not.
expensive care, if it can be done at
Yeah,
home,
yeah.
is equivalent and...
Yeah, I thought Katie Beckett was mental health too, but bottom line is, in this program, if you're eligible for the program, the state pretty much needs to do what will keep you in your home. I mean, the bottom line is, most institutions aren't a place for children. And so I think the state has recognized, and everybody's recognized, there are some people that are simply going to be very expensive, and there's not a lot anybody can do about it except for hope that their lives are better because you're there. And the same with the traumatic brain injury program. Again, expensive program. This is for people 16 and over. And I don't know if there's been any impact on the war in Iraq or not. I understand there was supposed to be head injury, but I don't know the numbers on that. You might want to talk to the state on that, whether there has in fact or hasn't been an impact, because I don't know the answer to that.
And prior to the initiation of this community-based TBI program, the state of Vermont used to spend hundreds of thousands of dollars for people in out-of-state facilities. There were rehab facilities for people with TBI, and many of those folks were able to come home, and now we're not having people go to those facilities. They come home instead, and we provide the service with one-on-one care in the community.
And the EPSDT is early periodic screening, diagnosis, and treatment. Basically, that's a mandate to the state to provide needed service for children who are eligible. So that's not really a program, that's a mandate. What the next chart is, home care across a continuum. This is where we think that we offer something special when you're considering healthcare reform. Because home care goes all the way from prevention and wellness, from birth all the way to death through hospice, and all of the services are there. I'm not going to go through the whole chart, but only let you know that we deal with children at birth, and we deal with people as they die, and everything in between. So we do cut across a tremendous continuum of care.
And just as an example, let me throw out a very popular thing we do, are foot clinics. Now, foot clinics are for people who are older. They either can't see their feet or they can't reach their feet, but everybody needs to have their toenails cut and their calluses filed. And it is such a benefit to the community that home health agencies will do foot clinics in senior centers all over the county. And my agency is here in Washington County. I think we do about 16 clinics a month. spread at different places throughout. And we charge people for it about, I think they pay $12 to come and they bring their own basin. But it is just such a popular program, and something, when people say my feet are killing me, it's true. If your feet aren't taken care of, if you can't ambulate, if you can't get around, other bad things are gonna happen. So, that's one of those really low-cost, simple wellness prevention kind of things that we do that I think really has an impact long-term.
Okay. Again, we're on the old health reform. We have care coordination teams already. As you know, one of the pressures for health reform is to reduce hospitalizations. That's where the money is. It doesn't take a genius to figure that one out. Hospitals without home health couldn't do that. They simply would have people backed up. So hospitals, we have a symbiotic relationship with each other. They need us and we need them, and I think we work together. We think we can help lower costs, and we do have universal access in Vermont, which is pretty significant. You don't get that. Not only do you not get that, as far as I know, you don't get that anywhere else. One of the partly by mission, and now it's mandated, is that we take all comers, regardless of what their program is. And most agencies, even some of the VNAs outside of Vermont, don't have to do that and don't do that because they can't. They will say, a VNA will say, we've lost, in another state, we've lost this amount of money and this is it. Now it's time to do something else. So you get a lot of patients shifting around in other states.
Peter, I'm a family doctor, and so primary care being a foundation of what we do and how we reform the healthcare system is, I think, really important. And part of that foundation is the blueprint and the patient-centered medical home. And a lot of the things you're talking about evolved also through the community health team model.
Right.
Could you tell me a little bit about how the agencies and the blueprint kind of integrating that service of a community health team and a care coordination team through the home health agencies?
I'm going to let these guys
or it
do
didn't
that.
work?
Sure. In Washington County, we do have, of course, the blueprint is active,
Yeah.
and we have a community health team. So our clinical director and another person is a physical therapist, we call them our rehab specialist, every Monday morning meet with that team so that they're reviewing patients and cases on the community health team. So our folks are able to have input into how home care can help either get somebody out of the hospital, avoid a hospitalization, or provide some mechanism for management of their disease. So, we feel like we're very integrated, that we're also able to introduce difficult situations to the community health team and get advice from them and really do that coordination for all the services in the county. So it's been very, very good.
You don't see any overlapping or things that you guys might have been doing all along, really, even before the blueprint came along?
Well, and I can only speak for Washington County. We do have a nurse in Washington County who goes out and does some coordination, but it really, at this point, it doesn't feel like overlap because we do so much coordination. There are some things probably if that nurse were not available from the blueprint, we might have one of our social workers doing some of the kind of work she's doing to help that person find other services that are going to help them stay at home. But because we communicate so regularly, we're kind of spreading that work out. We're not duplicating it for the same people.
From the other side, because I think we're the most rural anyway, agency, that we also have a blueprint that is started in Newport. And we have 2 teams that we work on. And when they were looking at protocols and how, so that we would prevent duplication, I actually sat on that. They wanted somebody that could address policy issues, how we were going to do this. And so we were trying to look at who did the teaching, how soon did we go in, how were we going to utilize people. And just a couple weeks ago, we did sign an agreement with the SASH folks. They're hiring our hospital nurse who sits on the team for the blueprint to be the wellness nurse in the HUD housing. So we are trying to look at that because we don't have a lot of folks up there in the kingdom, and so we've learned to put many different hats on our head and go try to prevent duplication.
I think a state assessment of our relationship with the blueprint would be similar to the blueprint itself. Some areas the blueprint is active, some areas less active. I think some areas we're actively involved, some areas less so. The blueprint's what, 5 years old now, 5 or 6?
Yep.
When it started, I would think it's fair to say home care wasn't being considered. But remember, it started as a diabetes and health, heart. So as the blueprint has evolved, we've evolved with it. I think we weren't considered in the beginning, but now I think people in the blueprint realize if we're going to talk community care, we should work with the community care people. So the evolution is to be more inclusive of us over the last few years. And it's getting, every day it's a little more inclusive than the day before. I guess this is what we've already said, basically. We do care coordination. We have close working relationships with physicians, hospitals, nursing homes, rehab facility, behavioral health, and so on. We are skilled at managing chronic disease. That's been something we've done for an awfully long time, long before I got here. One of the things I should tell you, which I don't think I put it in the slides, is when I took this job in 1983, it wasn't exclusive, but for the most part, home health was a 7 a.m. to 5 p.m. business, pretty much. Not exclusively, but much of the business was in that time. And much of it was acute care when people have just left the hospital, so on. The business has evolved tremendously over the last 30 years. And now it's 24/7, 7 days a week. Every single agency has numerous 2 a.m. visits, 3 a.m. visits. So if one of your jobs is to deal with staffing problems, I think it's fair to say that most agencies don't have staffing problems 7 a.m. to 4 p.m. Where you get into staffing problems are 3 a.m., Christmas, weekends, but all the times that people still need care. So staffing problem is different by hours, and it's different by days. So I think that we don't have any trouble getting nurses right now. Come back 10 o'clock tonight. That's much more difficult. So we'll move on to, I thought I'd just show how wonderful we look compared to everybody else. If you look at our 4-year growth, this is financial. And I got this from your website. I got this from the Bishka website. Basically, over the 4 years, our total income went up 8%. The total expenditure for all healthcare, not just that group, went up 27%, hospitals 29%, so on. Our average increase was 2% per year, considerably below the average. So just as I said, a few minutes ago, is whatever pressures you're having to keep home healthcare costs down, it sure isn't because of home health. If everybody were at that 2%, you probably wouldn't even be here as a board.
We noticed this when we reviewed the expenditure analysis with Mike the other day.
Good. I'm glad you did. So here's the challenges we think we have. And these are only some of them, but these are the challenges for here, for Bishka, for Medicaid. One is Medicaid's got to pay its bills. I mean, it really does. Well, not just for us, but for everybody. Now, maybe that's an evolutionary process. It's not going to happen tomorrow. But the home health agencies can't continue to lose $5-6 million a year. It just can't happen. And Medicare, we don't have there's nothing we can do much here about Medicare, but Medicare, home care is got cuts this year, it's scheduled for cuts next year, it'll probably get cuts the year after that. There's a couple of reasons for it. One is obviously the whole federal picture. How do you rein in what's going on in the federal level? And unfortunately, some of it is because of bad actors in home health. Some home health agencies around the country have made 20-30% profits, crazy profits. So MedPAC, I assume you all know what MedPAC is, looks at them and say, well, this is nuts. We can't have 30% profits. Let's cut everybody. Forgetting that, well, you know what, the VNAs haven't been doing that. They've been serving everybody. But it's likely, my guess is the future for Medicare is if we get any raises, they'll be small, if anything, and they might be down. The other challenge is we really ought to be connected into Vital or whatever. And I should tell you, I'm expecting to, I shouldn't say I've got it. I think I said had received. We've got tentative from Hunt Blair's office that we probably will have some money to figure out how we can get us in with everybody else. But I haven't got an official letter, so until I get that letter. But I realized I put a more positive on there. But I think, it's probable. In fact, I got an email today saying my member of understanding is coming. But if we're going to have a real health system, a home care nurse has got to be able to go on our computer and figure out what happened at the hospital. And the hospital's got to be on their computer and figure out what happened at home health. With all this phone calling and faxing and all that. It's crazy, crazy expensive stuff.
Right, and now, of course, all of our agencies, our nurses and our physical therapists, all of our professional staff are on laptops. So they, several times a day, transfer information so that when that nurse is making the 3 a.m. visit Peter's talking about, she can get the up-to-date information from what happened during the day at the home health agency. But for it's all internal, we'd like to be able to share that across providers.
And I think I think the state wants to do that too. I don't think there's any question that the DEVA folks want to do this too, but it's just taken a lot longer than I thought it would. This next chart gets into our why we got to pay better. Look at this chart. This chart, by the way, is created by the Department of Disabilities and Aging, not by me, from their finances. But if you look at the chart, the top line is, let's go to the bottom line first. The bottom line is how many agencies lost money from operating. And then the top line is the top line is operating expenses. 9 of 12 lost money from the revenues they got in from giving care. And then after you throw in the town funds and fundraising and bake sales, whatever else you do, 6 still lost money. This chart can't continue many more years. It just can't be this way. This chart has to be, that lot of bottom line, we can still lose money a little bit on operating, I suppose, because there is town funds and stuff. But if that bottom line doesn't get better than that, we're going to be in big trouble. But there are opportunities. It's not all, there are opportunities. We do think we should, we would like to be included in your discussions in health reform. We think we have a lot to offer. We already have experience managing per diem, prospective pay, and all that kind of stuff. If you don't know, as I said earlier, we're paid, at least in Medicare, on a 60-day episode, but in the hospice is a per diem?
Yes.
Per diem. So we've got experience already. As you're moving toward different funding systems, we've already been there. We have lots of end-of-life experience and infrastructure for managing chronic care. And let's see what I'll put. Provided incentives for technical support. We do think we want to be on the exchange, and we're hoping that'll happen in the next couple of years.
And all of the VNAs, we really work closely together too, so we share expertise and share programming. One of the things we did this fall is we started a program to have all of us do the same chronic disease management program. It's a researched, terrific program, national program, so we had everybody get together in central Vermont and trained 3 or 4 nurses from each of our agencies. They're now doing train the trainer in each individual agency. So statewide, we're all using the same educational materials, the same coaching techniques to be able to, that are, as I said, well-researched program, and we're all doing it the same way across the state, all the VNAs. So I just think that's one of the pluses to our network, that we really are, and because we're not competing with each other, we share with each other, and we can do a unified approach.
Can you say a word about the telehealth monitoring?
Yes, telemonitoring again is when we think about the growing need, but we also know that it's difficult to find good experienced nurses to do work. So if you've got a need going like this and you've got the people who are available going like this, you've got to have something to fill that gap, and we think technology is one of the things to help with that. With a telemonitor, at my agency here in Washington County, we have 60 telemonitors. So they're just about the size of a little transistor radio, and they're installed in a person's home. We use them mostly for people with congestive heart failure, with diabetes, with chronic lung disease. This little monitor sits in their home, and in the morning it comes on and says, "Good morning, it's time to take your vital signs." The person sits down in the machine, and it directs them through. We gather their weight, their heart rate, their oxygen levels, and their blood pressure. And that all comes back to one central computer at our agency, where we have one RN who then is monitoring 60 people on a daily basis. And so, then because it's a computerized system, it graphs everything. There are red flags that come up. So it's very intuitive and very clear whenever there's some kind of an issue. The monitor also then, after it does all the measurements, asks this person a series of questions. We do just 3 or 4 questions a day. They can change daily. We have like 60 questions to choose from. And it might be something like, is your pain worse today? Or are you having more trouble breathing today than yesterday? All kinds of clinical questions like that. So it's a tremendous amount of information. And what's so wonderful about it is it really allows you, especially a condition like chronic, congestive heart failure, there are subtle differences that if you don't pick up on them for several days, all of a sudden the person can be in crisis. And with this daily monitoring, it just makes such a difference. My agency, the national rate of home care patients being hospitalized nationally last year was 29%. At my agency, it was only 15%. And we really owe that to telemonitoring, because we had people who would be admitted to the hospital 15 times a year. Once we got a telemonitor in their home, they were hospitalized maybe once after that in the following year. So, and we do so much education also. That telemonitor nurse calls the patient and says, I see your weight's up a little bit today, your blood pressure's up a little, what do you think's going on? And then they say, that was great Chinese food last night. And they begin to make the connection. So there's lots of education, and it really builds on people's self-care abilities and people's even motivation to take care of themselves and eat better, because it's almost like biofeedback. I just can't say enough about the program. We really think it's fantastic. Unfortunately, there's no funding for it. We started our program with a grant, a $40,000 grant, and then we've done matching grants. We've done all kinds of things to get more money for this program. It costs us about $100,000 a year, but nobody reimburses for it. Blue Cross now will, but we just don't have that many Blue Cross people on it. Medicare does not, and we've been working with Medicaid, and I'm hopeful that Medicaid may be willing to start reimbursing for telemonitor services.
We also have the program, and it's beneficial to us because my furthest outpost is 100 miles to get a nurse out and back into the office. And so what it does is allow us to see what's happening with patients, so it can actually cut down the number of visits that we have to put somebody out. We just got our 3rd USDA grant, and this is allowing us to put cameras in, and we're going to start to look at wounds and other types of things where people are moving. So I think we're the first in the state to get the cameras, and we're at the phase where our technical people are working with us to see how that's going to happen, because actually it will have to be specific homes we can use this technology. But I agree with Judy, it's a marvelous thing. It cuts down on the number of contacts, actual physical contacts, and particularly in a rural area, this is really important, and there is no reimbursement source for that at this time. But it does help us with the number of staff. When staffing to get a number of staff that we need, this is really important to help supplement that.
Like some of the opportunities that we have on the next slide is, we think we would like to work with Medicaid to get away from fee-for-service to something else. But I should tell you, we've been working with Medicaid for 8 years on this. So it's not going to happen tomorrow. And it's not part. There's a lot of reasons for it. One is there a critical mass to do this at any specific agency? I mean, that is an issue. The Rutland VNA, maybe 7 or 8 years ago. Anybody remember John Dick?
Yes, I
Yeah, I remember John Dick. Those of some of us. John Dick. We worked with John Dick on a proposal that was based on VNA of Boston's proposal, because they do prospective payment for their Medicaid. As far as I know, they're the only agency, and they're a specific agency, and they do it just themselves in their state. And I think we were talking about risk corridors, and if we lose over 3%, or if we make over 3%, we would give it back, and that kind of thing. I do think Mark Larson is interested. He has gotten sort of a general idea of what we would like to do, but fee-for-service is probably just isn't going to cut it. If we go to something different, we can manage our organizations. Fee-for-service really doesn't allow you to manage much. except for manage each visit, and that's not going to cut anything. So we're hopeful that in the next few years, we can at least do a pilot somewhere on fee-for-service. If it doesn't work, we'll find that out. If it does, it would be beneficial for everybody. And the same with choices for care. We would like to see that something else than by visit. Now, we're sort of a little bit halfway there, I should tell you, or we're not halfway there yet. There is a proposal in this year's budget on the case choices for care that would pay case management on a monthly basis rather than a fee-for-service. So it isn't the whole program, but it is sort of putting your toe in the water kind of a thing. Whether it's enough money, that's another issue, but I think there is some movement with Dale runs Choices for Care. Medicaid, we've haven't made a lot of progress, but we've always had people, and Susan Basayo was very interested, and then she wasn't there anymore. But I think, I'm hopeful that we'll make some progress on that end. And then finally, if you want to know who to call or who to email, there you go. And if you want to call me, there I am. That's it. And we had hoped to show you a video, but there's no sound. So people something there talking with no sound isn't going to really do much.
We also have our annual report for the small agency, since there's two that were been sitting on the board of the Chittenden VNA, and just to kind of say that there's all different size agencies in the state and what that means, and many times when you're looking at a program or how something's going to go, we have the feeling up in the North Country that the bottom line is looked at the larger agencies, and it's much more difficult to be in an area such as what we serve. So I did bring, you can see that we save paper, it's tiny, there's color, and I did bring one on our hospice program. So if you're interested, they are here.
And I guess we'd like to, any questions you have about how we can get involved or what we think we have to offer beyond what you've seen on these sheets. And obviously, if there's anything here that you want more details on, these are sort of, everything here is a bit of an outline. We can give you more details. So.
I'm still intrigued about what would prompt a for-profit home health agency to come to Vermont. Given what you all and what I've seen being on the board, we struggle with in terms of business decisions and mission and our social and moral responsibilities, plus the regulatory climate. That always really right from the start intrigued me. Do you have any thoughts about that?
It intrigued me too.
I actually had one of their members say to me, if they had realized what the environment was, they probably would not have come to this state. So I think that things have evolved, that maybe when the decision was made, things changed. And
I do think, and you can talk to them, I do think they're using Vermont. This is the only place where they do hospice. And I think they're using it as a test market for their hospice to see how it goes. If it goes well here, they're a very big company, and we're lucky. I mean, there's some for-profits out there that less than honorable, but this isn't one of them.
No,
this is a good one.
we did that work too.
Yeah.
But just one other question I have about hospice, and hospice utilization in Vermont, kind of by national standards, is low.
Right.
I've looked at hospice length of stay,
Right.
utilization in each of our health service areas. What can we do?
Well, we actually, just interesting you asked.
Yeah.
When you have some time, go on my website. There's something called Start the Conversation. It's just beginning. We're working with all the agencies in the state. We are hoping to improve hospice through better education at all levels. Patients, families, physicians, nursing homes, even with our own staff. The very beginnings of this program is now online, and you can get some idea of what it means.
Did everybody hear that? Start the conversation. Okay, that's what.
And
yeah.
you know what, because what that's about is for people to choose hospice, when a person is terminally ill or severely ill, they have all kinds of treatment options offered to them all the time. So, and if you're that person and you're very sick, you're probably thinking you're going to choose between those treatment options. So the whole idea of choosing hospice instead take some real, sitting back and thinking, okay, do I want quantity or do I want quality, or, what are my last days gonna be like? Are these my last days? Can I go there? So this whole project that we're doing is to try to start that conversation, to have, before we're all severely ill or terminally ill, let's have some of those conversations so that if I can talk with my elderly mother about what she might want to do when and if, we're gonna know that and not even have to, when she's offered all those treatment options, she might be able to say, I've thought about this, that isn't what I wanna do. And I really think that's certainly a way to save some healthcare dollars, but a real way to save a lot of people a lot of stress and anxiety and discomfort also.
2 years ago, recognizing just what you said, we held various focus groups around the state. I think we had one in Burlington, a couple here in Central Vermont, Rutland, and then one in Red River. And we brought in physicians, nursing homes, clients, family members, and our own people. How come people don't use hospice more? And it was telling. If you're interested, I did post the results on my website. If you go on the website and go down to hospice, and it'll be, I did a results of each of the 6 settings, but there is a general executive sort of summary of all of them. But it was interesting. It was very, it wasn't troubling, but it was a learning session. One of the problems was we made the mistake of telling people about hospice, but not telling them really that it was a benefit, that their lives would be better. We tell them, well, we got all this technical jargon of, well, you're going to get this service and you're going to get this service, but nobody understood that really their lives were going to be better by hospice. So some of it was our own fault by not educating our staff to really explain what hospice is. It's really a benefit for people. It isn't just a program that finances here and there. And there was some misunderstanding at the physician level. There were some physicians that didn't really trust hospice, I think, and so we need to deal with that. One of our weakest areas was our penetration in nursing homes was low. Now, for those of you who don't know, if you are dying in a nursing home and you get hospice, you still get the VNA. You still get the hospice. It's just the way the federal rules go. And our penetration in nursing homes was low, and it continues to be low. And I think the Nursing Home Association recognizes that, and they've been working together. We're actually, 4 of us associations are working together on the Start the Conversation and more. It's VENS, which is the Ethics Network, VAHA, the Nursing Home Association, and VPQHC. The 4 of us are working together in a project that we're hoping over the course of a year that we can improve the numbers and especially improve the average length of stay. I think it's around 29 days, and that's just money losing. Well, it's not good, plus it's money losing.
And this Start the Conversation project has worked somewhere else?
Yeah, North Carolina.
Okay.
We're using their, the people I'm, it's coming through my office, but other people are running it, so I'll miss details. But the way we learned about it is people from Rutland VNA visited North Carolina, and they are, just by explaining the program better in those terms, start the conversation rather than you are dying and you can get this benefit, but let's start the conversation about what you want your life to look like should you be terminally ill. In North Carolina, it's made a big difference. They have a different name. We're
Begin the conversation.
What is theirs?
They call it Begin the Conversation.
Yeah, and they wouldn't let us use that.
We couldn't get.
They wouldn't let us use that, so we'll
Right.
start the conversation. So that's fine.
I think there's been a real cultural change though, because about 20 years ago I went to China and I was asked to present on hospice because we were one of the first 26 demonstration sites for hospice in the country. And in China, it was the physicians and the nurses, they really didn't like my presentation. It was a disappointment to me because, but they felt it was taking hope away. And one of the things that I think has happened to the hospices in Vermont that is bad is that they're looking at the hospice programs and saying, you're not giving the service what's happening in your agency. My agency educates all the time about hospice. And what we're finding is because of the technology that has developed over the time, because the length of stay when our program started in 1980 was over twice what it is today. But we're not controlling that, and we have worked with the doctors and worked with the oncologists. It's not unusual for them to call, and patients, you know, there's very, there's a variety of treatments. Some of them, you know, I wonder where it's going to go from being in the business as long as I have, $48,000 for one shot. But people are looking now, and they feel that they can be cured. And the other thing that's very different in my world from being in home care for the past 43 years is the advertisements that you see in magazines, that you see on TV, that you hear on the radio, that's talking about, come to our hospital because if you've got cancer, don't feel bad, we can fix you. So I think that, you know, when you're looking at the VNAs, it's not because the VNAs don't have staff or they don't want to take the patients on. It's because there has been a change in terms of when the referrals come. And there's real tension on that, you know, that they will call up and they'll say, one of the major hospitals, we're sending somebody home, we think they'll die by the weekend, and they're sending them home on a Friday. That is not hospice care. That actually is, you know, you can put them on home care, but that's really not addressing the fact of having people look and plan what they want when they get into a terminal illness. So I think that it's going to have to be you know, a multi-provider and utilizing the total community, you know, the religious folks, et cetera, to get back. When the program first came out, people were looking at that this was something that was there for them and not looking at the technology. It feels very different today than it did back when in 1980 when that program was put together. But the rules and the regs stayed the same. So they haven't updated themselves even to change with the cultural changes that are now hitting folks to use it.
Yeah, the program's likely to change, although they've been talking
It will
about
have to change
Yeah.
because the regs are exactly the same as they were put together in 1980.
what we have to get rid of, and it has changed a lot, and it's not as bad as it was before, but the let's try one more thing mentality is difficult.
Well, people
And
were-
if I were a physician, I probably would be there too. If I were someone, I would say, well, let's try this, let's try this. At some point, you got to say, well, you know, it's a difficult, there's no easy answer. And I know the whole issue of, the issue gets very complicated, especially when it gets to be political. There's never a good answer at the political level for hospice.
Who's running the show?
Go ahead.
I have a question about the idea of your participating in payment reform pilots. There are sort of three approaches that we've talked about in these meetings of bundle payments or sort of a per member per month or global budget and then a population-based approach. Could you envision yourself trying to go in with, let's say, hospitals or physician practices into one of those sorts of pilots as one question, or do you think it would be best to try to do it more within your own network? And secondly, among those three approaches, you mentioned the per member per month idea as being one that might fit the best, but how do you feel about the others?
What do you guys think? This is a tough one. Whenever, you know, the devil's always in the details.
Yeah, right.
It certainly makes sense that everybody go in together, to then you get shut out. I mean, if you had a I know they're trying the duals project. I assume you're all the duals project. It appears to me that the way it's evolving will be a proposal that'll have some sort of capitated program where one organization would manage the community-based services for all the players. In other words, if it were, say, Chittenden VNA, for example, someone came into that program who was duals and they needed mental health, they would have to make sure it got done. Now, rather than just saying, you get it from them, it would be better. So that kind of idea works. I mean, makes sense. It works or doesn't work, but it makes sense. The details are always difficult. So one would hope that if you go down that road, that the providers would be able to give the care that is needed, whatever that happens to be. The proposal that the VNA of Rutland had presented, I think it was similar to Medicare. It was a payment over a certain time period. I don't think it was just a month, but it was probably certain payment over a certain period, like a couple of months, similar to, it was a per payment over, but they didn't want, right now, the Medicare pays us 160 different amounts, something like 162 different amounts. Well, we don't want Medicaid to deal with that. So it would be much simpler, maybe 3 or 4 different payments depending on. But anything is worth trying, I think, because where we're going now is if the rates continue not to go anywhere, it won't really matter because no one's going to be in business anyway. So it would make sense to try something different, whatever that different happens to be.
And there's some beauty to having the hospitals and the home health agencies and the nursing homes all kind of working together too, because if, for instance, in the coming year, Medicare won't be paying hospitals if a person's readmitted with the same diagnosis within 30 days. I think that's roughly the way it is. So, we're thinking that hospitals are going to be very motivated to make sure they're not only referring to us, but they're giving us all the information we need to take care of that person so that they're not going to be coming back. And there are certain things we could all do if we were working more closely together. And like we work very well and very closely with our local hospital, but still, we're realizing that when you have somebody who's a new diabetic, for instance, they're in the hospital and they begin their teaching. And diabetes is one of those conditions that people really need to understand because they have to follow a certain diet and treat themselves and sometimes give themselves medications. So when they begin in the hospital, especially if it's somebody who's diagnosed for the first time and they're being educated in the hospital, but hospitalizations are short. So they're just there for a few days and they're given all these materials and this education, and then they go to the home health agency. Now the home health agency is using a different set of educational materials. It's just even simple things like that. If we would make sure we're all using the same thing, and so it really be seamless, and so it's a handoff. We know what that person covered in the hospital, what needs to happen next. We can reinforce that, go the next step, because it would all be a planned program. I think those things would happen more if we had more financial incentives to be doing that. But, it's always a worry for home health agencies. We're small potatoes budget-wise when you compare us to a hospital. So we'd really want to be sure that hospitals were recognizing how much money we needed to do the important work we're going to do.
And we're sort of uniquely poised in Vermont.
Well, I was just going to follow up by saying you can imagine that under any of those 3 models, a hospital could have a real incentive to avoid readmissions for people with CHF and therefore pay for your telemonitoring.
Yeah.
It creates a real synergy.
Mm-hmm.
Yeah, I suspect if one of your goals is to decrease rehospitalizations, the closer we work together, the more that's going to happen. And I think you're pretty fortunate in Vermont. I mean, the bottom line is our hospital, I don't even know if I got it to the slide, but the rehospitalization rates in Vermont are lower than the national average anyway. So you're going from good to better rather than from bad to good. That doesn't mean you can't go from good to better and keep going down the aisle, but there is a for-profit, but the bottom line is the competition level in Vermont is much less than any place else. I mean, in Boston, there's 150 agencies. So if you're a discharge planner, you've got what am I going to do? We don't really have that problem here. So the ability to work together is probably easier here than most places. So you got an opportunity to do that.
Anyone else? Anyone in the audience?
Well, thanks for having us.
Thanks for
If
coming.
you want to see the video, go onto our website.
Absolutely. Thank you. So now I'm going to hand it back over to Anya for the chair report that I put down at the bottom of the agenda. If you,
Yeah, I don't think I have anything to report. I apologize for being late. I was up in Vermont. Came before a meeting. I don't think I have anything to report. You're welcome. And we'll meet again on Thursday. I can't remember what the agenda is. Oh, Hunt Blair is talking about the HIT plan on Thursday. Thank you all.
thank you.
Thanks.
I didn't count this.
I hear all these names.
Not invasive, are they?
Yeah, great.
You go three different ways, you go. Most people.
So you do camera? This is who you really are.
I'm in down here at CAMaVT.
Oh, okay,
I'm in business.
Thank you very much.
My desire is to bring people have solutions to get this people. That's my desire.
Well, I'm talking about how
The board has that, all agencies have that.
Looks at the money and makes sure there's but as we're putting things together, those meetings, it's not to give the response time to get it done.
Probably
That's
new
what
age.
insurance companies have done. It's so difficult. Like sometimes.
Your literature.
No, I see it.
We made
It's in another
So in the long run, that's not a good system.
Thank you.
Nice to meet you.
And that's what all the fraud cases are.
Well, then, you know, I didn't.
Lying about the sick visit.
Yeah, you know, I didn't, I thought they were supposed to be counted. You guys know? No, the whole 6 visit thing was a joke. There's some agencies that do 3 visits a day. Are you kidding me? I mean, 3 visits a day. I thought that was weird.
Well, I think the important thing is what we want, but it's also,
And that's the other thing.
And when she came to Vermont,
There's 2 ways that these guys can do. One is, you get more money, if you can do 5 visits,
and she does have things done on people ever so.
you only made 5 visits. The other way is, when you're doing therapies, 12.